speaker. The next talk was evidence and experience in medical management of DME and DR. It was supposed to be given by Dr. Narayanan. Now, Dr. Narayanan is the head of clinical research at LVPI and senior consultant in the Department of Retina in Anant Bajaj Retina Institute. Now, he was unfortunately not able to come, so we have a recorded presentation which we will now play because it's an important topic. The number of people practicing medical retina is increasing day by day.
Good morning, everyone. I thank AIOS for giving me this opportunity to present on evidence and experience in medical management of DME. We all know there are numerous anti-VEGF agents available for the management of diabetic macular edema, starting from pegaptinib to bevacizumab, and then we had ranibizumab, aflibercept, and recently we have brolucizumab and perisumab. So with all these molecules of just anti-VEGF, and other than this, we also have steroids which are approved for management of DME. It can sometimes be confusing as to which agent to choose for the management of diabetic macular edema. There are numerous studies which have compared these anti-VEGF agents, and there is also one study on the pivotal study of DEX implant, and also comparative studies of steroids and anti-VEGF agents. But we probably won't go through all the studies, and it's not easy to remember all the study details. But the point about these studies is we should at least know what agent is good or most effective in terms of both visual acuity as well as drying of macular edema. And if we have to choose between two drugs, is there any evidence to show that one is better than the other? One of the first studies, which was a comparative study between ranibizumab and actually triamcinolone acetonide, with or without laser, the protocol I study of DRCR, at the 5 years of follow-up showed that the mean visual acuity gain in eyes who received ranibizumab injections with deferred laser, or you may call it as only anti-VEGF agents for most of them, the mean improvement was about 10 letters. 10 letters is about 2 lines. Let's say 2 lines means 624 to 612 or 618 to 69 in general. And if you see the eyes, if you subdivide them into eyes with better vision at baseline, that is to start off with. So those eyes which had 20/50 or better vision at baseline, they gained approximately 5 letters. If you see this graph, it's the y-axis is number of letters. So 5 letters is 1 line. You see that the previous slide which I showed, here it showed 10 letters overall, that is 2 lines. But if a patient has good vision at baseline, they gain 1 line. So it's kind of counterintuitive if someone believes that those who have good vision at baseline will improve more. The point is that those who have good vision at baseline improve less, but since they were already good to start off with, they still remain good. Protocol T was a comparative trial between aflibercept, that is Eylea, bevacizumab or Avastin, and ranibizumab or Lucentis/Excentrix. And this was a very important study. For most of the last decade, we had only these three anti-VEGF agents. So again, in protocol T, what it showed that eyes which had worse than 20/50 vision, similar to protocol I, they gained much better vision. Means both aflibercept and ranibizumab are quite similar to each other, but the red line, which is bevacizumab, had very less gain in vision compared to aflibercept or ranibizumab. But if you have a baseline vision of 20/50 or better, Now, in these eyes, all three injections performed very similarly. So, one take home could be that if you have a patient who has early vision loss due to DME, you probably can start off with any of these injections. There appears to be not much of a difference between the three injections. But in terms of OCT outcomes, aflibercept has the best drying effect compared to ranibizumab or bevacizumab. So in protocol T, the retreatment criteria were more strict in the first 6 months. Any edema you have to treat, unless the patient is 20 by 20 and dry. But if the patient has completed 6 months, you can hold off on the injections even if there is edema. So if the edema is stable and the vision is stable, you may choose to not inject in these patients. The number of injections in protocol T was about 15 injections in 2 years. Faricimab is the new drug which was launched in India in January, and Yosemite and Rhine trials were the main trials for DME, and it showed that patients with faricimab treated with 8 weeks or even PTI regimen of 12 to 16 weeks, they showed equivalent results to aflibercept or Eylea, and many patients could be maintained at 16 weekly intervals, that is 4 monthly injections. If a patient has very good vision at baseline, you can choose to even observe them as shown in protocol V. You don't have to inject all patients with edema if they have 20/25 or good, better vision, as this study of protocol V showed. So the Indian guidelines published by Dr. T.P. Das et al. Recommends that anti-VEGF should be the first line of treatment in central involved DME, and laser can be a first line for non-central DME or even central DME with good vision. And surgery for VMT and ERM should be considered. I would just like to present one case, cataract surgery done in both eyes earlier and was diagnosed with non-proliferative diabetic retinopathy with CSME, had received already injections, Avastin and Ozurdex before she came to us. She was 20/100 in the right eye and 20/40 in the left eye. The left eye showed neovascularization with extensive capillary non-perfusion. OCT showed a large CME with some intraretinal hyperreflective dots, some discontinuity of the ellipsoid zone and external limiting membrane. There was intraretinal cystic hyperreflective material in the left eye, which is again not a very good prognostic indicator. A lot of high reflective dots in the left eye. And this patient's blood pressure was 200 by 100 millimeters of mercury, was restarted on antihypertensive. So the point is you have to systemically evaluate these patients. This patient was advised ranibizumab injection in both eyes and also pan-retinal photocoagulation in both eyes. The edema did subside with some improvement in vision in both the eyes. The inset is the baseline. But I'll now skip uh, to the overall treatment, how many injections this patient received. The point is that this patient had recurrence of macular edema repeatedly, and the patient had to be given multiple ranibizumab injections, but then was switched to brolucizumab last year. And with brolucizumab, there was a better drying effect, although the visual acuity did not improve much. But and this is the left eye, but in spite of that, this patient had recurrence of edema after 3 months. So with brolucizumab also there can be recurrence, obviously, but these patients require less frequent injections. And with brolucizumab, the macula more or less used to dry, and the patient has been maintained on brolucizumab injections with stable vision. So in conclusion, DME, we typically start with anti-VEGF injections. We switch in about 2 to 3 injections. Steroids are used for maintenance for the most part, Very rarely steroids may be used as first line, like patients with stroke or heart disease, recent, or if they are already pseudophakic with good vision. And edema is a very important biomarker and it's very simple determinant of treatment decisions. And I also would urge that everyone should get trained in injections before they start giving injections.
Since he's recorded this thing, we